So how deeply are we thinking about what's informing our practice? And by informing it, like the things that we just assume are true in our practice and just operate under that kind of implicitly. Is it helpful for us to kind of look at a 10,000 foot view of our practice and see what are things going on around our practice and how we're defining ourselves that might influence our practice and then definitely limit our ability to really grow as a practice and a profession in general. We'll talk in this episode about some of the limiting ways we look at ourselves as physical therapists. We'll talk about how we kind of limit ourselves when we look at ourselves in musculoskeletal as manual therapists and really defining expertise under just a manual therapy flag. We're going to talk about some strategies to really diversify your learning community so you don't just get stuck listening to the same people, going to the same conferences every year, and just walling yourself into confirmation bias. So you're in for a ton of good clinical expertise, critical thinking, and philosophical thought processes. Hope you enjoy the episode.
This is the Modern Pain Podcast with Mark Cardula.
Welcome to the podcast, Matt.
Thank you very much, Mark. Thank you for inviting me.
So Matt, I obviously know you pretty well. Matt and I had the opportunity to hang out. He has actually family that I found out years back here in Phoenix. He's got in-laws that live here in the Phoenix area. So we've hung out personally and we've hung out at the San Diego Pain Summit. I actually got to know Matt a bit online through Twitter's, I think, where we initially had our contacts, where a lot of my professional relationships have developed just from admiration of folks who are posting good stuff and putting good materials out there. Matt's really a quality critical thinker, clinical reasoner, and we'll link to a lot of his work. He's got a blog. Is still writing a bit, I think, with some things, and we'll talk about that. But Matt, if you don't mind, do you mind introducing yourself to the folks as far as like your background? And I know you're up to a lot of things these days. We've talked about some of your busy pursuits that you have going on right now, but I'd love it if you could share it with the audience.
Yeah, no, at all. So thank you very much for inviting me on the podcast again, Mark. It's good to see you again. I'm a consultant physiotherapist working in the UK. Folks on the podcast may wonder what a consultant physiotherapist is. So a consultant physiotherapist, as it is in the UK, is a physiotherapist who works across kind of 5 main domains. They're seen as a clinical expert, and I think we're going to be discussing a little bit of that in the podcast today, as well as they take a leading part in education and training, research, and leadership across systems. So the journey towards consultant practice is still, I think, relatively in its infancy. And although consultant practice has been around in the UK for over a decade, I think there's still some sense of it's relatively early days. So there are different conceptions of what consultant practice is. And so that might be another topic of conversation in a second. So I live in a place called Bournemouth on the south coast of England, and I've been qualified since 2003. I qualified from the University of Southampton, did my undergraduate training there, and I did postgraduate training at the University of Brighton. So I've been taught by folks like Neil Langridge, Claire Hebron, Kellett Rydhall, Chris Mercer, Guy Camby. In the UK, they're really good and well-known people in the field. And many others, including Nikki Petty, of course, and we may be referring to some of her work as well. And in some of my postgrad stuff, I've been involved in a number of different research areas, one of which, one topic is around clinical reasoning and developing clinical reasoning skills. So my areas of interest really are around critical thinking, clinical reasoning, which is usually philosophically informed, and integrating various forms of knowledge into practice. So I have a role in the Musculoskeletal Association of Chartered Physiotherapists, which is a membership organisation of AAOMPT. And I've done, I think it's the equivalent of what you guys do in terms of fellowship training to become an MO, or part of an MO rather, for AAOMPT. So I've done the equivalent in the UK. And I'm a member of the executive committee of the MACP in knowledge, what I would call knowledge mobilization and transformation, as opposed to translation. And so there's good reason why I hold that position as well. So.
Yeah. So nonetheless, you're a busy individual, and always, it's interesting to just kind of see what you've been up to. And I know you just recently were working to, and correct me if I'm wrong, because I sometimes jumble it, but talking about clinical expertise and that kind of pursuit of clinical expertise in the roles that you spoke about there in the UK. I'm just curious if you can kind of discuss, because I think this episode we want to chat about expertise, because a lot of clinicians are thirsty, they're hungry. We have a lot of younger clinicians who listen, and I think it would help just to kind of help them see what's a good path. I mean, we've obviously spoke to some of the path you've taken to get there. There's various paths. There may not be the one only path for everybody. But maybe a little bit about the project you're up to, and then maybe we can get into a bit about, some of the kind of keystones and major kind of themes of how maybe.
Oh, yes. Yeah. So you're referring to the complex clinical reasoning program. So Bev Harden and Amanda Hensman-Crook, this is a few years back, approached me. So Bev Harden is she is the deputy chair of so we have Suzanne Rastrick, who's the chief allied health professions officer, and Bev Harden's her deputy, and she's also takes a leading role in allied health professional education at Health Education England. Health Education England just actually this month is going through a merging program with NHS England. And a few years ago, I was approached to see how we might be able to tackle a particular problem. And that particular problem was heading towards how healthcare professionals, non-medical healthcare professionals, could improve their sense of clinical reasoning across a multi-professional framework. So, folks who are interested, there is a kind of movement towards advancing practice, which is a level of practice across those four pillars which I mentioned before, which is clinical research, clinical practice, education and training, and leadership. Those four domains working at a master's level of equivalency. Now, you may say, in the UK or elsewhere in Europe or in the States, or surely it's just a question of going on an accredited program or going through some kind of institutional process. But as we've all recognized, there's nothing quite like working in practice to gain the expertise across those practice. What I'm saying is you can't just go to university and acquire the knowledge, skills, and expertise to apply that in practice. It has to be something that's at least in part developed and embodied in practice. So we've all experienced, and I've heard even in the podcast actually very recently with yourself, Mark, talking about how, and this has happened time and time again, where clinicians are given some scaffolding of knowledge, which they have in their undergraduate training or their pre-registration training, whichever level that is, whether that's master's or whatever. And then they go out in practice and they feel completely ill-equipped. This form of program training was flipping that kind of model on its head. And it was saying, well, actually, what we need to do is this large body of workforce, this large body of non-medical workforce, which includes physiotherapists, occupational therapists, speech and language therapists, all the AHPs, including, and outside of AHPs, nursing, midwifery, and so on. All of that large non-medical workforce, they have lots of practice-based knowledge. These are people who've already got their experience, a significant degree of experience. But they all shape their clinical expertise and their knowledge within the context under which they practice. So how can we how might we be able to support the development of clinical reasoning skills that not only meets a master's level of equivalency or has the capacity to do that, but also shapes how it would be applied in practice? And the way that we did that was to make it practice-based, make it supervisory in nature, as opposed to taught in a very kind of didactic sense, very much situated forms of knowledge. So it wouldn't matter if you were a pharmacist, for example, who was talking to a patient or a person who'd come into the pharmacy, who has complex multimorbidity and has got polypharmacy, and that pharmacist needs to be able to make really, really high level decision making about what the next step should be, in lots of ambiguity and uncertainty. That kind of practice-based knowledge is similar but very different to, say, I don't know, a respiratory physiotherapist who encounters a challenging situation on the ICU where there may be ethical challenges about whether or not a treatment intervention needs to be appropriate, but there's pressure from a medical workforce saying that some kind of intervention needs to happen. So what we wanted to do, and that was the program that I was part of, which was not just me. There was a big team of us. What we did is we developed 9 e-learning modules, which create some kind of foundation. And then we, with the help of Julia Taylor and other clinicians, we developed a supervisor pack, which was led and primarily developed by Julia, which gave the supervisor a way in which they could have and develop further skills in their supervision techniques and abilities to be able to develop those clinical reasoning skills across a whole breadth and depth of topic areas around clinical reasoning. And those came out of the e-learning sessions.
Sure.
So
sure.
those e-learning sessions were quite broad, and I can go into some detail about those. But that's a little bit of the kind of program. I hope that kind of gives the reader a little bit of background.
Yeah, no, I think, some of the things you mentioned in there as far as, the situated knowledge. And I think it's important, and I think it's a struggle I know I had and I still see with, early career and even like some of our students that listen, as far as understanding where their knowledge is currently situated. And it's situated in an academic environment where the use of that knowledge and how we apply it, and oftentimes it's in examinations and things where it's standardized, somewhat standardized tests as far as licensure tests here in the US and qualification examinations, I'm sure there in the UK. But then how does that knowledge embed itself into the clinic, and how do you develop the ability of that clinical knowledge that differs from academic knowledge, as far as the clinical knowledge of being able to take in a multitude of bits of knowledge of what we're considering we're knowing at the current moment, not just from our academic training and recalling, I always say, your PowerPoint knowledge of what you got in lecture and things in university, but then also the real human in front of you, and how does that really tailor to the situationally, the unique N=1 scenario you have in front of you with your patient. And obviously clinical reasoning becomes a huge part of that, as far as being able to situate that knowledge and bring it to the clinic. What are some ways you think, like an early career professional, somebody who's, or maybe even a student who's, because we're all chomping at the bit, and I love a lot of the students I interact with, they want to be good. They want to be really solid clinicians as quickly as possible, as we all should hopefully want to be. But, sometimes, the pursuit of just more knowledge, as far as that, like, and again, not wrong to have that good situated knowledge of what you've learned through PowerPoints and lectures, and even weekend courses sometimes can be like that too. But how do you recommend somebody really developing their skill in that clinical situated knowledge to where, hey, I can take what I've learned in the PowerPoint and on my weekend course or whatever it may be, where it's kind of, again, it's not situated learning where you've kind of experientially learned within the context of real human interaction with your patient. I'm just curious what you think would be some good ways for folks to help that process along maybe earlier in their career. Yeah.
It's a really good question. And I think this is still very much, I think, a really much needed area to develop. And I'm not confident there's necessarily a huge amount. I think there's lots of research gone into the area, but I would say it still needs further development. One of the things that I think is, so I'm going to start by responding in a kind of conceptual basis and then give some real life kind of concrete examples. So I think one of the ways in which we can develop this kind of process is to develop what some researchers in Australia have described as epistemic fluency. Okay, so that sounds a little bit complicated. Bear with me. Epistemic refers to knowledge. And much like, let's say if you learn a language, you can learn the words, but it doesn't necessarily mean that you're able to talk to somebody and understand dialect, and you can understand, kind of translate things in a real kind of, a situated way. So I think this idea of epistemic fluency is you referred to how do you take this multiplicity of different forms of knowledge to come with some kind of coherent kind of response, and how do you make that kind of decision come through? And I'd say, I think from an early career perspective, one of the ways is just to hold back from the idea that once you develop further knowledge, that you can immediately apply that very, very quickly into practice. So a real concrete example of this is, let's imagine you've gone on a sacroiliac joint course, and they've told you about positional faults, and they've told you about sacroiliac joint dysfunctions. And let's say they're now talking about sacroiliac joint treatments. What happens, and we've all been there, when you start doing this in practice? You start checking these things, you start assuming that these things are the case, and you start diagnosing lots and lots of things with sacroiliac joint dysfunctions and stuff like that. And then you start treating these people with this particular paradigm, this particular frame. And so the pursuit of knowledge, I would say, is something that reflecting on my own career, what I used to think, in order to be a really good clinician, it was just as simple as knowing the research evidence, really, knowing the evidence, accumulating your knowledge. And what I would say to young career clinicians is to continue your exploration to develop your knowledge, but then hesitate with that knowledge, and then have discussions around your communities of practice in how and where does this sit? Where does this sit? Who does this sit well with these particular patients? So, for example, if you've gone on a sacroiliac joint course, you discuss that with your colleagues, and then suddenly you're going to have a multiplicity of different viewpoints. Some people who be very much with you, not many now, I don't think, on those kind of positional faults of the sacroiliac joint, but historically that would be the way. And you would have lots of people who would probably say, particularly those with different degrees and levels of experience, both positively, and negatively, toward that knowledge that you've just acquired. And then have a conversation with them and say, how do you guys apply this in practice, and how does this make sense for you? By all means, apply some of that knowledge and see what your immediate responses are. But so tinker with knowledge is what I'm saying. So tinker with it. Use it in practice. Discuss it with your communities that are around you, and then reflect on it and kind of evaluate on the basis of this plurality of information, your colleagues, your experience with patients, perhaps what some of the research says, then kind of situate it in what makes sense for you. So much as you might say that evidence-based practice is a model by which you would kind of consider clinical decision-making, you could also see it as a way of sense-making of knowledge in itself, that you're gathering information from various different sources, but you're going to try and situate it in terms of the priority of how helpful it is for working in particular cases. And I think this is one of the biggest challenges, is with any form of knowledge, that knowledge, if it comes from, say, a textbook, is general knowledge. One of the challenges is how do you apply that general knowledge into particular cases, which requires a heck of a lot of thinking, reasoning, and ethics in order to situate how you're going to apply that in particular cases. And here's a paradox. When you think about your previous experiences, of how things have worked in the past, you're taking particular cases, particular forms, and then you're applying it to general cases. So there's this kind of fusion between where you're taking propositional knowledge from general cases and applying it to particular things. And then when you're applying this in practice, you're taking it from particular cases and then applying it to general themes. What might this patient look like? You know, you look at the referral and you start creating some assumptions. Okay, this patient may present in this way. This is what I might be thinking down this line. And all of this is shaped by your, it creates forms of bias, which of course isn't something I don't think is negative. It's something that we can't it's something that we have to accept. This idea that we can get, wash away all sense of bias because research tells us the ultimate truth, is false. That's a false idea. It's just that there is different forms of corrections. When I say corrections, adaptations to our knowledge and how we apply them in particular cases. I hope that isn't too abstract, but do you see what I'm getting at? So,
yeah, no, absolutely. I think it is just that kind of, and I think you put it very well as far as, the knowledge from the general to the specific, but then as clinical, the illness scripts we form in our head and different things that we kind of recognize this is what specific cases that have responded well to certain interventions or maybe certain approaches in the past, specific, cases where the individual, the specific, then we try to generalize to maybe another situation. And so it is, one of those challenging, tussles to have mentally. And I agree with you 100%. There was a period there, I don't know what happened, and maybe it was something that got published online, I don't know, where everybody was like calling out everybody's bias, and again, it was, I think in the general, the thought behind it, I think is good. I think it's important to recognize that we're humans and inherently we will carry bias. It's just part of the way sometimes heuristically we try to navigate situations and minimize cognitive load, sometimes in a good way, sometimes in a bad way, of course, but I completely agree with you. I think as long as we're kind of consciously aware of it and kind of try to manage it as best we can in our situations that we encounter, I think it can be, something that isn't necessarily some taboo. And I agree. The thought that you're going to wash your thinking and reasoning and actions and behaviors free of bias is just, that's not how humans work.
I was just going to kind of, again, I want to try and make this really concrete for the newer clinicians as well. So I think you're a big advocate of this as well, Mark. You really do. You're very proactive with developing those kind of communities of practice. I think having groups of mentors, there are certain qualities of people around you that you aspire to because of various values that you have. It might be humility, it might be skill, it might be knowledge, it might be communication skills. There are all sorts of different skills. No one has all of them. But if there is a group of people that kind of can work really well together and work off each other's skills in a very positive and cohesive manner, it's those communities of practice that I think can make a really big impact. So I would say that the social systems and organizations that you're part of really do help shape the types of practitioner you become or through this process.
Yeah. No, I agree. I think, some of the challenges with the community building, because I'm 100% like surround yourself with folks that, are the people you want to aspire to become. With that comes the thoughts of like, are we walling ourselves into a tunnel of confirmation bias to where we're not seeing maybe other, epistemological perspectives of what other people consider knowledge, or maybe other groups consider knowledge in a situation. I can just speak for myself. You may have had similar experiences where, my early training was very manual therapy focused and not bad. It really helped me to grow. Obviously, we've recognized its limitations, as you had alluded to. I was very much trained in the positional faults of the SI joint and things, and we're recognizing the weaknesses of that maybe approach and lack of reliability and all those good things. But how do you think somebody can approach that? And I don't think it's necessarily bad. I just think, when you where it becomes maybe less ideal is when you kind of surround yourself by the same narrative in the same group chronically, where I only attend the same conference every year and hear from the same group of people. I guess my question would be, how do you just diversify your community to enough to where you avoid, I mean, obviously there's going to be maybe common themes and common thoughts of your culture you're in and things like that, of course. But I mean, what are your thoughts on like purposeful diversification of that community, that learning community around you to help make sure you don't maybe fall into a overly biased way of kind of interpreting the world in front of you?
I think you're absolutely right, Mark. So much as I'm saying, on the one hand, surround yourself with communities of practice, I think it's reciprocal in a sense. In other words, when I talk about reciprocal, I mean I think there has to be a few key elements. One, which is a real sense of openness. That's a personal sense of openness, that you're open to different perspectives. So when entering dialogue, be open to the idea of changing your perspective or mind, because else there's no point. The other thing is that the diversity of voices really has to be there. So if you're finding that you are in with the same kinds of people as you, that could be problematic. I'm not saying it is, but I'm saying that there is a potential problem there, and that's where I think the diversity and inclusion is a really important kind of factor to help develop our communities of in general, but in particular of knowledge, which is what our topic today is around that. So, for example, I really enjoyed your podcast. I think it was your last one, or the last couple. All of your podcasts I really enjoyed, but I've been listening to a couple of them, and there was a chap who was talking about the need to secure an enclosure of manual therapy in AAOMPT. Okay, which, because the idea of getting rid of the manipulation part of AAOMPT instead of it being musculoskeletal was seen as some kind of threat. Okay, or at least that was my interpretation. Because actually, hold on a second. There are other people within the organization who don't have the level of clinical reasoning skills, knowledge, and expertise that I have, or people like me. But I would say that this is a potential problem. In the one hand, I totally agree. I've done the training myself. I certainly can kind of relate to what that person was saying. I've forgotten his name. Who was he? What was his name?
That was Mark Shepard.
Yeah, Mark Shepard. Lovely guy. Came across really well. The only critical kind of perspective that I would say is that by saying, no, hold on a second, what we're doing, because we're keeping this kind of concept of manipulation, that clinical reasoning and that kind of thing, is we're kind of trying to push away, understandably, from this idea of professional enclosure. Okay. And I would say that you could say, well, there are good reasons to do that, to create further legitimacy, expertise, and elitism. But is that the best for the patient? Is that the best for the people that we are serving? And on the one hand, you could say yes, well, because we're developing that high level of skills, knowledge, and competence. But on the other, you could say, well, actually, patients don't just need hands manipulative practice. And the concept of musculoskeletal is far broader than that. And in fact, you could probably go broader and broader and broader. But I would say that for us as a profession, as a physical therapy profession, I think we have to let go of some of these. I see this as an anchor, a potential anchor point that's going to stop us evolve. So this is a bit of a segue, but it kind of comes to your point around there is a risk that we are going to enclose our way of thinking, which is going to not diversify our thoughts, perspectives, and we are going to basically sit in an echo chamber, and our biases and our perspectives will just keep going round and round, and we're never challenged. And I think that is a problem.
No, and I 100%. Yes, I would agree wholeheartedly. I was frustrated, and I know there's more to the discussion of why, like AAOMPT, our body was very adamantly against moving from manual therapist to musculoskeletal therapist. I was very disappointed in that decision. Continue to be. I understand some of the discussions, but I'm more definitely currently, unless somebody maybe can talk and maybe there's some legitimate reasons. I know some of it's structural and administratively, the way we've set ourselves up in the US is we have an orthopedic section, and then the AAOMPT is kind of, so there's already like the broad orthopedic. And honestly, to me, I mean, I just think then fold underneath the orthopedic section and be a little subspecialty group within it. But we need to broaden our look at, I don't think it's helpful to cordon ourselves off, like you said, and define ourselves under an intervention, even by title. Just, I think it just, I just think we can do better to broaden our approach to open up the window of like considering alternative forms of knowledge. Now, with that said, I know a lot of the fellowships who function under AAOMPT are very much in tune with, this whole discussion of person-focused, person-centered care, and, incorporating, newer, bits of pain science and some of the things we know, and psychologically informed care. So I think there's some positive movement, but I still think structurally there needs to be some reorganization personally to help broaden our definition of what a clinical expert is. Because I definitely think defining it under just a manual therapy flag is highly limiting, and it doesn't always go in line with the human in front of you.
Yeah, 100%. And if you look at, I think we can put this in the show notes later, the masterclass, that paper that Nikki Petty wrote. And in fact, she dedicated a lot of her her doctorate and postdoctorate career into the context of clinical expertise. And in that, there is this kind of movement from a therapist-centered perspective, which is toward a person or much more person-centered approach. And if we were going to take the context of models seriously in terms of biopsychosocial, why would we reduce it to the context of, even if we were to say that manipulative skills were both, in some sense, diagnostic and interventionalist, and and say that there's a lot more in that in terms of an embodied way of understanding people, which I'm completely on board with. It's still a narrow viewpoint. And I can't help but think that some of the ways of thinking around this could be a really good podcast for a future episode. And we could discuss this furthermore, but I can't get away from the idea that, late stage capitalism and neoliberal practices are shaping the profession towards this enclosure to maintain the status quo, to maintain this kind of just development of particular forms of knowledge and not really listen to other voices that are out there. So I think that's a dangerous move, personally. I don't think it's a particularly proactive move, but I'm happy to be told otherwise. And I'm happy for people to reject what I say and come back with counterpoints on it. I just think it's a bit of a dodgy move when you're looking at kind of the sphere of healthcare.
Yeah, I agree. I think if anything, science is teaching us is that we need to start working together and start speaking the same language around what humans are going through when they're struggling with, complex, painful situations, because it's such a complex phenomenon that requires knowledge from multitude of areas, and to kind of define yourself narrowly, I think is missing the boat on where things are headed, or where research says, gosh, we sure need to be. So I think the broader we can be, the more interprofessional we can be, and the more holistic, I guess, is another term of, being able to take multitudes of perspectives beyond just maybe even just a strict musculoskeletal perspective, but definitely more broadly than a hands-on manual therapy perspective. And again, I will say, with having been through a fellowship, they're very much in tune with, and then Mark had mentioned our last episode ago. It's really being more precise with where manual therapy kind of sits within an encounter. So I think they do, but I still think there's some improvements as far as we could do a lot better by defining clinical expertise outside of that box. I just think it could be much more better. It would help us as clinicians where we don't get walled into, this, I need to be a manual therapist approach. I don't think that title is one that's useful or helpful. I mean, definitely a therapist who may utilize manual therapy interventions with a well-reasoned, person-centered application. I have zero preference, but I wouldn't say I'm any really labeled therapist. I would try that. Just I think risks us to be biased, but
and I think there's something to be said around the permeability of our professional boundaries isn't a bad thing. For example, in the UK, you can be a non-medical prescriber. Now, you might say, well, hold on a second, that's stepping on the toes of biomedical practices. But a lot of what we do in musculoskeletal practice is help people taper and help people deprescribe. So, other aspects is psychologically informed practices. So we do this with other professions. And I think we probably need to kind of think about the permeability of our professional boundaries and be open to, different ways of things rather than thinking inwardly. That's one of the risks, I think, if we, because I feel I'm very passionate about AAOMPT, I'm very passionate about developing our, knowledge skills within physical therapy. I just think we need to think broader. But yeah,
and
we can move on.
Yeah, no, that's all right. But and this podcast, we start one way and then sometimes we go another way, which is fine. I'd rather follow the conversation and where it leads and we can always change things up a little bit as we move. But where do you think, because this, again, we're getting a little bit off of where we were initially, but I just think this like categorical, knowledge, categorical thinking of which really limits you to thinking within this self-determined, boundary of where our knowledge sits. Like we're a physio, and there's been some physios I know who've been kind of resistant to, I don't want to be a psychologist. And, I don't want to get into some of these things. Like I'm not a sociologist to start working with this person. I'm not a social worker and again, not that we need to go deep into some of these, infringing on, other professions, but practice patterns. But the patients of us are saying we sure as heck need to. These boundaries are becoming barriers, especially in the United States. It's so inefficient to where you have all these ologists who this person gets cordoned off into how many fractional pieces. I always joke, it's like we have so many tree specialists here in the U.S. and rarely does the person get a forest perspective. It's just like, and usually I'd argue it's a forest problem. Like it's just a very complex, all these trees interacting versus like our healthcare system that's set up like that. And I think further, and you mentioned some of the things maybe behind this need to like cordon and protect our knowledge base and different things. I just sometimes wonder, and I'm curious what your perspective is like how do these professional boundaries help us as far as like to really best serve our patients? I mean, obviously there needs to be some degree of professional boundaries, but does there need to be some sort of redefinition? I don't know if that means new professions created or maybe better interactions of, and I think you're already seeing it, like you said, of, prescribing clinicians in the UK and different things where I think some of those practice, patterns, I do this, you do that, where we're seeing that there can be some overlap. I'm just curious where you think maybe that needs to head, or where if you were to be able to kind of steer the ship as like to help these boundaries be more, better serving our patients versus maybe this cordoning off and limiting our knowledge base when we interact with folks.
Yeah, it's a really good question. I think, and within your question, I think lies a way into the answer, and that is, what are we here for? We're here for helping people. Okay, and when we're saying helping people, what does that entail? One of the things I think that creates this situation where we're increasing there's a tendency to fragment the body into different parts, that we're becoming specialists in different body parts, is it creates the sense of legitimacy and this professional authority, which sits well in a certain social and political contexts. Let's just put it that way. And I think that takes us away, this kind of fragmentation. I think this takes away from the real needs of society and planetary health. I think we probably need to move away from what is professional identity. And there are a lot of risks with this. So if we start talking about one of the issues with the professional identity, the word, even the concept of identity, means that there is an essence, there is something of what the profession is. It's reducible to something. And as soon as you kind of step outside of that, then the idea of identity then becomes in flux. It becomes less stable, and if it's less stable, well, then that's problematic, and that leads us open to these unprecedented changes that may collapse the profession itself. So I think. I think historically this all comes down to the way in which the Enlightenment thinking has kind of thought about the body and fragmented ways of thinking about health and disease, and also how nature has been divided by culture. Nature and culture have been divided. So there's a whole host. I could give you a whole I don't want to be monopolizing your time on this. I think we could go right back to the Enlightenment and build up to where we are today and give you a really good account, a strong account of what the reasons why we're here today. But I think it comes down to these things: legitimacy, making sure that we maintain those professional boundaries so that we can secure social and political capital. And through that social and political capital, we can maintain some sense of fiscal certainty, particularly in a time where it's in such flux at the moment, right? So this isn't a good time to change, but I think in certain perspectives. But I think this is the best time to change because we are at risk, I think, as a physical therapies, of becoming even further fragmented because we no longer really see ourselves. We're kind of going to implode because we're only going to focus on ourselves and what our skills are. Or people are leaving the profession. I think people are going to leave the profession because they're going to be really disappointed in what they aimed to achieve in the first place, which was to look after patients. So I think that this will probably have a little bit of a kickback, what I'm talking about, but I think we really need to evaluate and have a really good look at ourselves. I think the work of Dave Nichols articulates it really well in The End of Physiotherapy and Physiotherapy Otherwise. And the question coming back to your point is, how are we going to break free from that? I would say, what are we here for? And how are we going to take things like the social determinants of health seriously? How are we going to take environmental context seriously? And if that means that we look back to our assumptions, then I think we need to do that. And I take it all the way back to our assumptions on what is the body, what is health, what is supporting, what is therapy, what is all of those things that we take for granted. Because I think if we do strip all the way things back down to those kind of concepts that we take for granted, it'd be surprising. We would be questioning why we're doing certain things, like pushing on somebody's neck on C2, C3 becomes now pretty small fry when you look at the bigger picture.
No, I definitely I can hear what you're saying. And I think it's so difficult. And I think sometimes, it's this professional comfort zone and this professional stability to say we grab this and we don't even recognize some of these implicit assumptions that you speak to of what we operate under. And if we just stepped back and took that 10,000 foot view of like really examining how we're defining body, how we're defining health, how we're defining pain, how we're defining things, it would really make us think like, why am I doing this? Doesn't make sense in those contexts of that. If I really question that knowledge of what I'm considering the knowledge of what is the body of the pain and stuff. It's tough. And I think it's uncomfortable enough to where people just want to stay in their body and stay in their organization that holds them to a thought of comfort and stability of maybe it is being the manual therapist. And I would argue for me, that was probably a little bit of it. It was very destabilizing when what I had kind of defined myself as a manual therapist. And as that was the ticket to understanding pain, was a very peripheralist, I'm going to fix it through intervening with the structure and didn't really consider all the things that we now know, like you mentioned, social determinants of health and all these things that, man, I agree. I think we're missing a huge opportunity to help a lot more people if that's what we're about. And you mentioned some very challenging things that pull at that push for us and politically, fiscally, and all these different things that I think we need to examine what's the true thing we're important for or what we're here for. And it's going to be interesting to see how it goes, but I would definitely second your thoughts on checking out David Nichols' work. He puts some very, look in the mirror physiotherapy. You need to, examine where we've come from and where we're heading and maybe think, is that the right way we want to go? Again, maybe that's a whole nother podcast. I need to get David on here. He gets my brain going as much as anybody, as far as he's got some really good viewpoints, very, very good kind of thought processes, and somebody that I think is worth chatting with. But I want to respect your time, Matt, and maybe we'll definitely have to have maybe a future episodes where we expand on some of these topics, because I could talk about this stuff. We could make a 4-hour episode and just cut it up. But I have to go to some patients here in a little bit. But where would you, it's hard, we've been in a few different directions today, but you've mentioned David Nichols' work. What else do you think, if you were to point some people in directions to maybe start examining this? We'll link Nikki Petty's work on the clinical expertise, because I think that kind of sits within our discussion as well. We'll link David Nichols' book, The End of Physiotherapy. Anything else or any other kind of things you would recommend people start working into, whether it be readings, articles, or things to kind of help them break out of some of the challenges we spoke to today? Yeah,
I think so I would, to try and really break out of some of the ways in which I think we've tended to focus. I think Philip Marich, the Environmental Physiotherapy Network, is a really nice thing to explore. So that'll be on a website. Just type in environmental physiotherapy. You'll see Philip Marich. He's done some really interesting work. I think Jenny Setchell's work, kind of looking at body stigma. And she is very involved with feminist philosophical approaches in physiotherapy. I think in terms of critical physiotherapy, I think Barbara Gibson in Canada, her work kind of expands a different perspective on what physical therapies might become. So I would say there are a couple of books that all of those authors were involved with. One of them is called Manipulating Practices, and that's open access, if you look at that, and also Mobilizing Knowledge. So those are two books which I think are quite nice to see how different critical physiotherapy kind of access points, I would say. Really nice.
Yeah, no, I've got a few of those on my to-read book or list, which never ends, of course, as I'm well aware of. But we'll link those in the show notes. So definitely, if you're all looking to kind of expand your thinking and break out of maybe the categorical professional boundaries that, as we've probably argued a bit today, that limit our ability to help people, hopefully you'll check out some of those resources and get some value out of them. Matt, I wanted to thank you for your time today. Like I said, we'll have to get you back on the podcast to start expanding on these topics. I always come out of your conversations better than when I went in, as far as really, and then scratching my head more than I went in, which is always a good sign. That you're making me think, which I like. So thank you for your time. Awesome. We really appreciate the work you do too, and the things you share on Twitter. Where can folks find some of your work online, just in case they want to read some of your work? Because I think that's also good stuff that speaks to a lot of what we spoke to today.
Yeah, so you can find me on Twitter, MattLowPT. I've got a blog post which I kind of need to get back to. Really, it's MattLowPT at WordPress. Those are the kind of two main ways to kind of contact and maybe get involved in some of the stuff I've done.
Yeah, definitely check it out. He's been a definite influence on my career to kind of really stimulate thinking and has been a big push. So thank you for that, Matt. I really appreciate your time and best of luck in all you're up to.
Thank you very much. And I look forward to speaking to you again soon.
All right. We'll talk to you all next week.